work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.
Hello everyone. Welcome to the Kirby Institute's International Women's Day seminar. My name is Bridget Haire, and to begin with, I'd like to acknowledge the traditional custodians of the land on which we meet. I'm living and working on the Gadigal land of the Eora Nation, and I pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islander people in the audience. Now, I'll begin with some administrative points. The format for this seminar will start off with presentations, so we'll have all of the 3 presentations in a row, followed by the Q&A at the end. You can interact by typing your questions throughout the talk. So to ask a question, you click on the Q&A icon at the bottom of the screen, and we really want to hear your questions, so please do that, and you can do that while the speaker speaks. It doesn't interrupt them, so please be encouraged there. The theme for International Women's Day 2022 is Break the Bias, and we've asked our speakers to interpret this through a lens of sexual health. In introducing today's seminar, I want to note that 2021 was a significant year for acknowledging the interconnected elements that make up women's sexual health and women's health more broadly. Just 1 week after International Women's Day last year, we had the Women's March for Justice, a nationwide outpouring of anger against sexual violence and gender discrimination. A triumvirate of 3 young women, Grace Tame, Brittany Higgins and Chanel Contos, led a national conversation of compelling importance. Meanwhile, in the United States, we've seen reproductive rights under constant threat. We've also seen worldwide women disproportionately bearing the burden of homeschooling their children while also working for a living, imposed by COVID. This morning's news has brought us 2 relevant items: a federal government decision to not add superannuation payments to paid parental leave, which entrenches financial disadvantage for many women. And on a more positive side, news that the Snow Medical Foundation has suspended the University of Melbourne from eligibility from its lucrative fellowship program due to its 3-year record of awarding honorary doctorates only to white men. So philanthropic funders are noticing equity, diversity and inclusion, and they are taking it seriously. We are very fortunate today to be welcoming 3 inspiring speakers from outside the Kirby Institute to talk to us about their research and its contribution to women's health. Just before I introduce the first speaker, though, I want to acknowledge the research that we conduct here at the Kirby Institute that contributes to women's sexual health. Projects include addressing STIs in pregnancy, cervical cancer prevention, screening and elimination across the region, with investigators there including Andrew Vallely, Lucia Romani, Angela Kelly, Dorothy Matulek, Michaela Riddell and Lisa Vallely. There's also some very important work on pregnancy outcomes by Lisa Vallely. Also programs on women living with HIV in PNG and Australia, which are led respectively by Angela Kelly and Ellie Carter. And Ellie is also leading work on consent and reproductive coercion. I want to further highlight Angela Kelly's work on HIV prevention in female sex workers, mother-to-child HIV prevention programs, and access to family planning for women and girls. Further, there's Mary Poynton's work with Positive Life on HPV-related cancers in women. Finally, Lisa Ma and Jenny Iverson have produced an extensive body of work in female sex workers in Cambodia, women partners of men who use drugs in Pakistan, and women who use drugs more generally. This work has highlighted gaps in harm reduction responses amid dual epidemics of overdose and violence. But to return to our speakers here today, we have 3 leaders in their fields who have each embedded their work in the communities that their research serves. And it's my very, very great pleasure to introduce our first speaker, Dr. Blessing Akombi-Inyang from the School of Population Health. Now, Blessing is an emerging early career researcher in global health who specialises in maternal, adolescent and child health, including childhood undernutrition and the double burden of malnutrition among vulnerable subpopulations, including migrants. Her research provides evidence for community-based interventions to improve health outcomes among vulnerable subpopulations, particularly in developing countries and low-resource settings, as well as among migrant populations here. I hope you'll join me in welcoming Dr. Blessing Akombi-Inyang.
Good morning, everyone. I'm Blessing Akombi-Inyang, just like I've been introduced earlier. And before I proceed, I would like to acknowledge the Daruwal people and the Gandigoro people, who are the traditional custodians of the land in which I'm joining from today. I pay my respects to their elders, both past and present, and extend that respect to all Aboriginal and Torres Strait Islanders who are joining us here today. And so I would like to talk on community engagement of migrant women. I just want to talk to us and give us an insight into what I consider, what I've been working on, or what I've seen, as a migrant myself. This is just a chat and a discussion and something that you can take home with, and that could shape some of your research if you decide to research into migrant health, or you have interest there. But first of all, let's talk about community engagement. While there are several definitions around community engagement, but the simplest term is that it seeks to better engage the community to achieve long-term and sustainable outcomes. So for it to be successful, it has to encompass strategies and processes that are sensitive to the community context in which it occurs. Now, it is imperative, therefore, to engage with communities in public health programs in order to identify their needs. So at the core of any community engagement is the need identification, identifying the need that a particular community needs before you can actually go ahead to engage with them. Now, within these communities, there are settings which offer a social context in which migrants engage in daily activities. So referring to migrant within the context of their community, there are some social things, there's some social context that influences their life and well-being. My talk today is actually connecting well-being of migrant, zeroing it down to the well-being of migrant within Australia. Now, these avenues, when you talk about settings, they actually help, they serve as avenues to promote health by reaching those people who really need them, for example, the migrant community. Now, one of these settings could be formed based on visa status. Now, it's a very sensitive thing, or it's an area that has really been overlooked because most times everyone is graded as linguistically diverse people and they are put into one category. But within there, they have two set of people that experience life and experience migration in two different ways. So in order to engage properly with this set of people, it's good to identify the context in which their life is surrendered. I'll give you a good example. Now, most research, when I go through a lot of research that I see online and research that people have been doing, you find out migrant and refugees are grouped together. Now, when you group those two set of people together, you undermine, there are a lot of things, there are a lot of people that don't get reached. Now, remember, when you talk about migration, some people migrate based on choice, they decide they want to migrate, and then some migrate not having that choice because of the situation that arises around them. So by the time interventions are being, rolled out, they don't get to reach some set of people because mainly those interventions are actually targeting refugees that don't that lack some social context, or some social context plays out on their life in a different way to the way it plays out to normal migrants. I'll give you an example. Most times, research that goes out is to help linguistically diverse people go into believing that these people probably they can't speak English, or they are suffering in one way or the other. Now, it's good to actually focus on those people, but then there's another subset of people that are being ignored in research, and their life is also being impacted. And these migrants and refugees experience deprivation and discrimination, and they experience a lot of things in different ways. For example, a migrant, a refugee issue may be around domestic violence, not being able to access health services, and all of that. Now, a migrant, another migrant, when I mean another migrant, I'll give you a good context. Someone like myself, let me use myself, for example. I came to Australia to do my master's, and I did a PhD, and we have educated people like myself that came in. Now, the way things play out for me, it's quite different to the way things play out for another refugee, for a refugee population. My issues may not necessarily be domestic violence, because I know where to go to get help. So there are a group of people that know where to get, but my own issue what prevents me from getting that help may be around fear of loneliness. What if? So when interventions are targeting to me, it should be more of my mental health, because of the way situations plays out for me. But in another context, probably people who come in from war-torn regions and all of that, there is even being able to speak English, being able to reach the health center, the healthcare, being able to assess all of that. Now, a lot of attention goes into that, which is quite good. But in all of this, I'm trying to bring out a point here that there is a group of people that are linguistically diverse, that are in Australia, that are being ignored, and these people need to be looked at into. This set of people are people that they are not as vulnerable, let me use that word, as the obvious people are, but they are people that life or their social context has played out in a different dimension. Now, these people are there, they are not looked at, they are suffering some maybe mental health, and which will deteriorate their health, and they start getting chronic diseases and all of that, but they never get taken care of, because you know what, they are too good to fall into the category of vulnerable. And then they are too, so at the end of the day, they remain in a section that gets overlooked. So there is a need that women, or right this International Day, those set of people that have been overlooked, migrants, women that have been overlooked, people that don't fall into that category of, oh, they can't speak English, or their partner or their husband is maltreating them at home, all those obvious vulnerable people, they are there, but there are some other people that are not very, and the population is increasing. COVID is gone down right now. People are coming in. You have a lot of international students that some of them will eventually stay back in Australia and probably get citizenship and all of that. They are coming, the borders are open. They are coming to do undergraduate courses. They are coming to do master's courses. They are coming to stay. Those people may not fall into that category of refugees that they can assess. So there is a need that more research should be done in that area to be able to look at what need do these people have, because they are educated, they know where to access those services, but what prevents them from accessing those services, even when they know they are. So at the end of the day, it may not necessarily be the obvious case of domestic violence. It could be more, and also it might not really be financial violence where there is a deprivation, because some of these ladies are educated. They can make the money, they can support themselves financially. So at the end of the day, what are those things that these other people need in order for to improve their life? So we are talking about well-being here of migrant women, and we have to look at the whole picture. So much attention has been put into one aspect, into one set of linguistically diverse women, but another set that is increasing has been ignored. So I'll put a call out there and say that for people like myself, that it looks like, okay, we are not vulnerable, but then watch out. Even in the workplaces, even in those places, there is a need actually for counseling services that are specific to these women. That actually, it looks as if they are financially stable, they are not under threat of financial domestic financial violence and all of that, but they also need to be looked into, need to be acknowledged. So that's my call here. It's more like a cry that, please, there is this group of women that are being forgotten. Their life look good, but their mental health might be suffering. They are not the obvious, like the refugees and all of that. And also, they don't have it, because remember, they came from a culture where they came from Africa or whatever country they came from. And most of these countries have patriarchal systems that they might have grown. So it's always a struggle, blending their education, blending their exposure with where they are coming from. So that they may be able to master it and make it look a little bit good, but their mental health is actually very, very unstable. And most times they can't even say anything because they are too up there to fit into the obvious refugee or the obvious vulnerable people. And then they are too, but even when they go to their own people, they look at them as being having everything, but still the context of their upbringing over the years still get to play around with them, and it extends in a lot of other angles. So my call today on this International Day, Women's Day, is please, while doing research and while looking at migrant people, migrant women, let's not forget those women who it seems as if they can speak the English, they have the jobs and all of that. Let's not forget that they also need to be looked into. They also have needs, and they also need support, mental counseling. So organizations should actually look into that. For example, I don't know if my time is up, but for example, COVID-19 has happened. There's a lot of pressure from, back home or back in their country to actually give remittances, because they now have that reputation of being stable. So the pressure, apart from the pressure of family, of work and everything happening to them here, they still also have that pressure to give remittances back home, because they've risen higher than just the refugee or just the vulnerable population. So at the end of the day, this subset of women that are greatly ignored go through a lot. But then their lives seem so good, so perfect, that people don't really see how much suffering or how much mental stress that they go through. And this plays out in a lot of other things in their life. So this is a call out, as I said earlier, this is a call out for this set of women to be looked. And it will be good when we're engaging with the community, we understand that their social context is a little bit different from the regular refugee women, which a lot of research has been done on. And then when engaging with them, engage with them at that level, so that there can be an improvement in their well-being, in their health. And I believe with this, we can see stronger, more empowered migrant women. We can see women that are able or willing to move the frontier in business, in academia, and all of. We can see all-rounded migrant women. So migrant women will not only be seen as vulnerable people, because it's when these migrant women are strong. Like most times, if you want to go into research into the migrant community, you need some migrant women on your team. So therefore, those women you need on your team, you need them to be strong so that your interventions can actually have more impact. So if you have an idea, if you have the will of wanting to do impactful interventions among the migrant community to improve their sexual health, to improve anything among them, you need on your team strong migrant women. But then, in order to build those strong migrant women, you need to also look out for them, that they are strong enough. And that is how you can engage more with the migrant community. Get on your team strong migrant women, and it will help community engagement with other migrants, with other refugees. Because at the end of the day, the whole thing is to be able to reach out to these migrant women to improve their health, their well-being, their sexual life, and prevent domestic violence. But as you know, the best way to interact or to penetrate a particular community is by going there with people that they identify with. And one of those people are migrants like themselves. So these migrant women that you're going to take into this migrant community, whether they are Indians or they are whatever, Asians, Africans, you need to actually be watchful for these migrant people that are pushing the front of your intervention. Make sure they are also okay, because it's what they have and what they carry that they will be able to help you when interacting with other migrants or with other people, because they understand, but they also need to be strong. So this is since we are in an academia environment and we have a lot of researchers and all of that, that's why I brought out this topic within ourselves. A lot of research is going out for other people out there, refugees, but within ourselves in the academia, we need to watch out for our migrant people like myself and other people, and make sure that they are also stable interventions that will actually make them stronger, so that from their empowered stance, they can be able to push more research and improve the lives of other women that are out there, improve their sexual life, improve their physical life, their financial life, because they will understand where they're coming from. So I think my time should be off if I'm right. I don't want to go over my time, but I think I've come to the end of my talk. Thank you so much.
Thank you so much, Blessing, for that very insightful talk and for bringing up that very important issue of how at a certain level, migrant women do get overlooked, and for making that very important point as well about how critically important it is for researchers, if we are going to be effective in that space, to actually have migrant women on our research teams doing that work, making the engagement happen. Very inspiring there. It's my great pleasure now to introduce our second speaker for today. This is Associate Professor Julie Mooney Summers. Now, Julie's research focuses on the health of sexuality and gender diverse people, primarily related to tobacco, alcohol, and other substance use. With Akon and Rachel Deacon, she leads the longest running periodic survey of lesbian, bisexual, and queer women's health, which is SWASH. Thank you, Julie. Great to have you here today.
Thanks, Bridget. We do like to go on about how long-lasting the old SWASH survey is. I'm going to share a screen because I need slides to talk, and also start by acknowledging that I'm coming to you from the land of the Gadigal people of the Eora Nation, which is where I live and work and learn and teach, and most importantly for today, research. So I'm going to talk to you about a paper that I'm writing with my colleagues Anya Andhurst and Rachel Deacon about the way that SWASH has dealt with gender diversity. And when Bridget, we've been working on this for a little while, and when Bridget mentioned this talk in relation to diversity and sexual health, this felt like a perfect thing to talk about. So I've pulled out some parts of that paper, which is almost close to being ready to submit. And so I'm going to start actually with an origin story that just quickly, many of you will have heard before, and you've probably seen this photograph before. And this is the, I guess in the mid-90s, when HIV diagnoses were still powering up in Australia, were very much powering up in Australia, there were concerns that lesbian identified women and other women who engaged with the gay community were at increased risk of HIV because they were more likely to be having sex with and injecting drugs with men who have sex with men. The findings of the 1995 Sydney Men and Sexual Health Project, which was SMASH, which is now GCPS, reinforced those concerns. As a result, workers on two projects at ACON initiated the Sydney Women and Sexual Health Survey, SWASH. They were supported by amazing researchers like Juliet Richters and Garrett Prestige, among others. The project sought to, and this is from one of the original reports, estimate risks to women in contact with Sydney's gay and lesbian community with the primary aim of finding whether further work was necessary either in research or targeted prevention campaigns. Fast forward to today, and SWASH has been running every 2 years since 1996, expanding to provide critical indicator data, not just on sexual health, but on preventative health, including cancer screening, on smoking, alcohol, and other drug use, on mental health and experiences of abuse among lesbian, bisexual, queer, and other non-heterosexual identifying women in Sydney. And it's been an important feature of LGBTQ communities in Sydney for those 25 years. It has high community recognition and engagement. Hearing SWASH findings through ACON activities or community forums or an article in Archer magazine allows not just survey respondents, but members of the community to see their lives reflected back to them. And I think that was especially powerful when such representations were rare. But SWASH hasn't simply reflected women's lives, and Claxon here, because I'm going to make a big claim. I think SWASH has also underpinned the construction of the very notion of LBQ women for those concerned with LGBTQ health in Australia. So it's really been the main source of Australian data about LBQ women for most of its lifetime. It's in many ways, SWASH has made LBQ women knowable for public policy. SWASH is the only research that's cited on LBQ women, New South Wales Women's Health Strategy. It's vital evidence in the review underpinning the soon-to-be released LGBTI health strategy for New South Wales. ACON uses it in policy submissions from mental health to homelessness, and organisations like ACON and Thorn Harbour Health use it in development of organisational strategy and seeking funding in developing health promotion programs. But over the 25 years that SWASH has been around, there's also been some considerable changes in public discussion and social acceptance, and some changes in legal recognition of trans and gender diverse people. Representations in popular culture have become commonplace. As insider researchers, Rachel and I experience these shifts amongst our friendship groups and community networks as people that we know change the way they describe, think about, express, and relate to gender. In 2017, as we prepared for the 2018 survey, we were becoming increasingly uncomfortable with the disjuncture between what we were witnessing in the communities that we were part of and the way that SWASH was dealing with gender. So in the paper that we've been writing, we're really exploring the process of designing in gender diversity, or designing back in, retrofitting, I guess, gender diversity, and joining a conversation around quantification of queer lives and what that means. I'll speak briefly to the main conversation that happens in that literature, which is about the kind of specific issue of gender and sexuality indicators. But the more substantial and difficult work for SWASH has been around applying a gender diversity lens to all the questions in the survey. Trans and gender diverse people have always been part of the SWASH sample as respondents and as the sexual partners of respondents. And the work that we've been doing has been really about trying to make the survey work better. And the complications and compromises and messiness involved in that project is important to talk about. It's often private work, and I think we need to make it public. So perhaps a surprising thing about SWASH is that we never asked people about their gender. It was simply taken for granted that respondents were women. Being a woman was an inclusion criteria that was enacted when peer recruiters approached somebody and the person agreed to do the survey that was for women. And the definition of woman has always been inclusive in SWASH. Trans women have been part of it since the very beginning. So this first problem was an easy one to fix. In 2018, we simply introduced the two-step question that ACON had developed around gender identity and sex assigned at birth. I'm going to skip over all of the complicated issues around those questions. To a consequence. So now that we asked about gender, we could exclude any men who might do the survey, and there was a handful, but we had an unexpected issue came up. We probably should have expected this one, which was, what should we do with the significant proportion of the sample in 2018 who reported a non-binary identity? SWASH has always been a survey for women. we felt uncomfortable excluding people who may have been completing SWOSH for years, but who were only now visible to us because we were asking directly about gender. In 2020, we conducted some post-data collection consultation to understand and think about this issue. And non-binary people from the community told us that people were filling in the survey because they had done so in the past. And so this was part of what they did, or it was an active connection with a community of LBQ women that they felt part of and connected to. Importantly, they may also have felt connected to or aligned with female or woman or femininity as part of their gender or identity or sexuality. And finally, in the absence of a general health survey, SWOSH might actually have been the best available means to communicate their health needs. So in 2018 and 2020, we kept I think it was 9% in 2020 of the sample that identified as non-binary. We had to think then about how to describe the survey. So we've always used a version of this phrase, women in contact with Sydney LGBTQ communities. It would have been an overreach to now describe the report as about women and non-binary people, because the non-binary people that we had in the sample skewed very strongly towards people who had been presumed female at birth. So we didn't have a broad representation of non-binary people. So we left the report title as it was, but we changed the way that we described the sample inside the report, and also how we talked about insights from that as LBQ women and some non-binary people. Flagging that non-binary people's identities and experiences and needs are not equivalent to and could not be subsumed into women's experience was an important message that came out of the post-data collection consultation. The conversations we had about non-binary inclusion in 2018 were generally framed as keeping non-binary people in the sample was an unproblematic act of inclusion. It was simply the right thing to do. Or at least no one we talked to about it felt safe to tell us that it was a bad idea. The same conversations that we had in 2020 were characterized by ambivalence. There was a strong sense from some non-binary people that they were tolerating an uncomfortable inclusion in a space that had always been clearly signified as a women's space. It's the women's survey, after all. Inclusion in SWOSH felt like a temporary accommodation. This is a dynamic space, as I hope you've gotten from the account I've given so far. Non-binary people are in SWOSH for now, and we're in the middle of data collection for 2022. We have not advertised the survey as for non-binary people, and we've done quite a lot of work with our peer recruiters around how to do recruitment around gender, because there's some very complicated issues around deciding who to approach and who not to approach. So in some ways, that adding a gender question to SWOSH was the easy part. When it came to gender diversity, respondents who were participating in the survey were being forced to find ways to answer questions that didn't fit them or didn't fit their partners, or skip the survey altogether. So the survey was making some kinds of lives and some kinds of experiences knowable. Equally important, navigating these questions could be a harmful experience for trans and gender diverse people. We committed to reviewing all of the survey questions for 2020, and we did a lot of difficult, terrifying, exciting, invigorating work. And I'm only going to talk here about one of those things. So the surprisingly most difficult thing for us to change in the survey was a question about sexual activities with men. So in the past, we had asked respondents when they last had sex with a gay or bisexual man, and when they had last had vaginal or anal sex with a gay or bisexual man without a condom. These questions spoke to HIV risk and were the primary reason that SWOSH existed. And in fact, the questions are pretty much the same questions that were first asked 25 years ago. And they had provided valuable data around HIV risk for women engaged with LGBT communities. But the questions assumed that gender told us something important about genitals. So a yes response to a question about sex with a gay or bisexual man assumed that the respondent had a vagina and that their partner had a penis, and in turn that sexual encounter was assumed to present a certain kind of risk for HIV. If the question was designed to capture risk associated with a penis and a vagina, then we weren't sure at all about the data that we were generating. Respondents had to decide what the question meant by man. A cisgender man, anyone with a penis, anyone who identifies as a man. Did a man who did not have a penis count? Respondents were having to navigate this and might reasonably answer the question in terms of gender when the question we thought had probably been designed to ask about genitals. We resolved this problem in a few ways, and one of them was a new question designed to generate specific data on sexual risk associated with sex involving a penis. The question we developed essentially was, did a vagina have sex with the penis? This adhered to our intent to decouple gender and genitalia, but gosh, it felt really depersonalized and cold and objectifying. So while we felt like the question might produce accurate data, the framing and the language, which very much reflect ACON's perspective around parts and practices, it did not feel like a SWOSH question, which had always referred to people and identities. Now I want to acknowledge here a concern that we have, which is echoing a terrible paper, and I would prefer not to be citing it, but I am, a terrible paper about the use of sexed language in communication around pregnancy, birth, and feeding. And the authors of that paper worried about alternatives to sexed language, that they said, so language that refers to body parts and physiological processes, which they talked about as being mechanistic, othering, and dehumanizing. And I see lots of resonance in the concerns that we were expressing and that they're expressing. However, we strongly disagree with the position the authors advocate for in that paper. And in fact, most of that paper we would disagree with. But I think we do have to recognize a moment of transition here. We are seeking new ways to communicate meaning and more precise meaning, while dealing with what Son Vivienne talks about as vernacular limitations. We may need new language, or maybe we just need to become more comfortable with the kind of parts and practices language. Either way, developing appropriate and acceptable terminology for everybody is uncomfortable but necessary work. In SWOSH, we had to conclude that genitalia was the key that, and what we were interested in this question, and so that's where we've landed with it. Our project to make the SWOSH survey work better around gender diversity is about revisions rather than resolutions. As the lives of our respondents change and the culture in which they make sense of bodies and relationships and sexual practices change, so the survey must change. We would not offer our current questions as a model for others because we don't think it's possible to future-proof these questions. And that's a really uncertain space to be in quantitative research. And while we agree with Karate and colleagues that we should avoid language that assumes participants are heterosexual or cisgender, or that certain behaviors are normal, the changes we've made in SWOSH did not come about through a simple act of our will. Even for a team of LGBTQ researchers, some of our team are also gender diverse, with a long track record of working in this area, working in collaboration with an LGBT organization. Addressing the cisnormativity in the survey was and continues to be a process. It required us to imagine lives, bodies, ways of being, and ways of having sex that are different to our own personal experiences and that we couldn't find reflected in the literature. Such acts of imagination are surely always at the heart of survey development. We think there's a political obligation to bring a consciousness to the limits of our imagination and a commitment to properly engage with marginalized people about their lives. Addressing cisnormativity in the survey and in our imaginations was achieved. That sounds final, and it's not, is still in progress, but it's achieved through the sustained advocacy and engagement and patience of our community partner, of peer recruiters, of gender diverse community members, and also by survey respondents writing feedback on the survey, because our community likes to give feedback, and aren't we lucky for it? When SWOSH first ran in 1996, no one imagined it as a periodic survey, never mind that it would run 25 years later. The questions were designed to reflect the social and cultural landscape of the time. And we don't say this by way of an excuse. Indeed, we are very confident that for its time, the original survey was both radical and inclusive. The problem is not what was done in 1996, but that as a periodic survey, we did not remain amenable to changes as social and cultural and political moments progressed. While building an evidence base for LBQ women's health, SWOSH also perpetuated data absences, potentially devalued some people and practices, and inadequately described the complexities of the communities it sought to reflect. There's a lot of work, we're doing a lot of work here. And I think there's a question about at what point in the last 25 years should SWOSH have dealt more directly with gender and gender diversity. I don't think we know that, but I think that we know it should have been sooner. Thanks, Bridget.
Thank you, Julie. And thank you so much for that fascinating presentation. It really is remarkable to reflect on how much our ideas of gender have developed and changed in that period of time. And I really thank you for that extremely thought-provoking presentation. And good on you for doing the work now. That's terrific. It's good to see that it's being
Look, in
done.
some ways we've been dragged to it, but we're here.
Now, it's my pleasure to introduce our third and final speaker. Let me remind you to be putting your questions into the chat. I'm sure you have many questions there. Our third and final speaker is Professor Debra Bateson, who's Medical Director of Family Planning New South Wales and has worked as a clinician, an educator, researcher and advocate in sexual and reproductive health and rights for almost 20 years. Debra holds honorary positions as adjunct professor at the Centre for Social Research in Health at UNSW and clinical associate professor in the discipline of obstetrics, gynecology and neonatology at the University of Sydney. Welcome, Debra. We're looking forward to hearing your talk today.
Thank you so much, Bridget, and thank you to Julie and Blessing as well. I have to say, I've learnt many things. I'm just going to share my screen now. So it's an absolute privilege to be here to celebrate International Women's Day with you all. And I too would like to acknowledge the traditional owners of the land in which I'm speaking on, and that's the Wongal land, which is a new land for me. We've moved to Newington in Sydney. And I also pay my respects to Aboriginal elders past, present and emerging. So I'm going to be talking about enhancing the sexual and reproductive health and rights of women with intellectual disability. And I'm going to start just with a little bit of a high level view, and then I'm going to concentrate on enhancing cervical screening for women with intellectual disability because of a new grant that has been received, which I'll tell you about. So the United Nations Convention on the Rights of Persons with Disabilities says that people with disability have the right to the enjoyment of the highest attainable standard of health without discrimination and respect for their inherent dignity and autonomy, including the freedom to make their own choices, and whether that's the choice to marry who they want, to have children or not have children. And Australia actually ratified this convention in 2008. I think another really good framework is this, comes out of the Bookmarker Lancet Commission, 2008. It's the framework that recognises that sexual and reproductive health and rights needs are universal, but some groups have distinct SRH needs. And this includes people with disabilities who may also, of course, be sex workers, be adolescents, be Indigenous people, be LGBTIQ people, for instance. And of course, everyone, all of these people have the right to make decisions that govern their bodies in relation to their sexuality and reproductive choices, free of stigma, discrimination, coercion, exploitation, and violence. But we know that there have been many, many injustices, past and present. So you can look at that photo of institutionalized people with intellectual disability. This went on for many years. This is taken from Canada, this photo, but we would see similar views in Australia, and some still continue today. As recently as 2012, the UN examined Australia's forced sterilisation of women with disabilities. And on the right here, this is Chanel Mckenna. She's now in her 40s. She's a disability advocate. She's become this. She was born with cerebral palsy, and when she was 11, her mother was concerned about her, managing her menstrual periods. Probably also worried about possible, sexual assault maybe in the future. And with the collusion of the school, they found a willing gynecologist, and Chanel had a hysterectomy at age 11. Below that is a picture of Depo-Provera injections. So these are given every 3 months for contraception, but can also be used for menstrual control, so it causes no periods. And certainly they've been misused. Depo injections have been misused for people of many vulnerable groups over many decades. And I've certainly, seen many women, less so recently, who come in with an intellectual disability with a paid carer, who's, the carer will often have poor health literacy, busy job to do, and they'll say, doctor, doc, can you give give my client her depot injection, and I'll say, actually, I need to talk to your client just to find out what she wants to do, because in fact, of course, her menstrual needs and choices are the same as any others. And so, really important. I just take my hat off here and just give a shout out to Ali Carter, who's led this excellent paper that you can see here on the sexual and reproductive health and rights of young people with intellectual disability. And I'd urge you all to read that. But of course, we still have abuses and injustices carrying on. This is the Royal Commission logo. The Royal Commission started in 2009. It's still ongoing in different contexts, and it is indeed revealing violence, abuse, neglect, and exploitation of people with disability. But there is a shift in harmful norms. We do know that there is more awareness. We know that parents, for instance, particularly of adolescents who are becoming sexually aware with an intellectual disability, parents can feel incredibly protective at this age. So sometimes we know that people with intellectual disability miss out on appropriate education, sex education. They don't get to see all these exciting resources. So I'm just putting up a few here. This is from the Family Planning Suite of resources. The other group that's really come out in the Royal Commission has really been some challenges. There's actually around healthcare workers, and I know we teach a lot of GPs around how to work with people, their patients with intellectual disability, how to support decision making. And we know that actually GPs can feel really out of their comfort zone. They feel lack of confidence, often wanting to do the right thing, but sometimes it's that balance of that protection versus autonomy, because really when people are being protective, generally it means that they're not supporting autonomy. And out of the Royal Commission has come this national roadmap for improving the health of people with intellectual disability. It's a 10-year roadmap, and it's particularly focusing on supporting health literacy for people with intellectual disability, their carers, disability support workers, and also upskilling, ensuring that GPs do have those skills. And this is one of my favourite quotes. This is from someone on one of our consumer reference groups. A good decision supporter tells you stuff, but still lets you decide what to do. A bad decision supporter tells you what to do. As doctors, we still need to understand the law. So, for situations where we can't, our patient hasn't got that capacity to make an informed decision, despite sometimes best efforts. So we do need to ensure that we do understand the law for someone who needs a substitute decision maker. And the treatments are divided into minor and major treatments. Major treatments are the depot injection I talked about, having a Mirena put in, having a procedure under sedation. Then that decision needs to be made by what's called the person responsible, who may be a spouse, it may be a parent. But then there's special medical treatments, and that includes the sterilizations I've talked about, as well as abortions, and that can only be made by the court. And I must say, I've had some very, in my 20 years, some of the most challenging times have been really with, my patients who've had an intellectual disability, but absolutely have the capacity to know that they want to be a parent, but everyone around them is trying to prevent them from being a parent. Sometimes it's the other way around. They know they want an abortion. But I want to shift to another slight shift now, because I want to just shift now to the elimination of cervical cancer. We've got, and I'm going to tie it in with intellectual disability. We've got the tools. We know that we can eliminate. We've got WHO goals for 2030 through vaccination, through HPV screening, and through treatment of precancerous lesions. We know we can actually reach it. But what we also know is that there's an 18-fold variation in global mortality rates. And some of these, highest rates are on our doorstep. We absolutely know that cervical cancer is a disease of inequity. And if we look at what's happening in Australia, we're actually on track to be the first country to reach the 2030 targets. But this is only going to happen if no one's left behind. And you might be quite surprised to hear that the current screening participation rate is actually only 52%, and almost 3/4 of people who develop cervical cancer are under or never screened. And this is a diverse group of people. So this is, we know, Aboriginal and Torres Strait Islander women. We know it's women of culturally and linguistically diverse backgrounds. We know it's the LGBTIQ community, people with a cervix. We know it's people with women with intellectual disability. So we have to say, look, elimination is our target, but of course, equity is our goal. And I just wanted to mention that in July of this year, we are going to have a game changer, which we hope will mean that we'll encourage and support those people who are under and never screened to come into the program, because everyone will actually have a choice to take their own swab. It's a low vaginal swab, just a simple swab like this, or have a clinician collected sample. But this hopefully will bring people in. But what do we know about cervical screening and intellectual disability? What do we know? What don't we know? Well, we don't have any national data. Certainly when I'm ordering a test, I'm not writing down whether someone's got an intellectual disability. There is prospects, and in fact, there's a wonderful person, Professor Julian Troller, who's the inaugural chair of intellectual disability and mental health at UNSW, and I've been chatting to him about the future possibility of data linkage, and with obviously all those ethical challenges, I can think of no better person to lead that. Just in terms of Australian and international evidence, then it does support overrepresentation in under and never screened groups. So some studies, I mean, they're small and they're relatively old, from 2010, showed around about 10% of women with intellectual disability having had a baseline pap smear. These are low numbers. And what are the barriers to access to cervical screening? Well, we know that there's social and economic and physical and sensory and psychological, as well as cultural, as well as fear and stigma and embarrassment. We know that there are higher rates of violence and sexual assault. We know there's low awareness and misassumptions by healthcare providers, caregivers and families about an individual screening needs, perceptions of not being sexually active, and just deprioritizing this, as well as a tolerability, but again not actually asking people. There's lack of access to sex education, easy read information and resources. I've talked about health providers, lack of training or knowledge, and also poor past screening experiences will certainly put people off having another screening test. Just on the right here, these are some resources from the Just Checking series from Family Planning. This is about encouraging people with intellectual disability into all cervical screening programs. This is Taryn and Tamsin. Actually, I do love this video because we talk about the human Pavlova virus. I like that one. But you may be thinking to yourself, where does self-collection fit for people with intellectual disability? Well, the answer is we don't know. But I must say, I have actually been able to offer it to under and never screened eligible women. It's limited at the moment. So what's happened in that situation? I've had 3 women, in fact, with physical and intellectual disabilities who have been unable to take their own self-collected sample, but they don't want a speculum examination, to have had sexual trauma. But they were very happy for me to take that low vaginal swab. And now we're putting that in the national guidelines, which is very, very encouraging. What is the clinical best practice around cervical screening and intellectual disability? We need to obviously meet people's specific needs. We need longer and multiple appointments. We need to always address the patient, include the carer, but only if the patient wants it, and ask permission to use, to talk about intimate subjects and sexuality in plain language. We need to always make no assumptions about what's already known. And it's always about supporting health literacy and improving capacity for informed decision-making. I've got to make sure that the follow-up referral pathways, if I'm referring someone to a gynecologist, and I've practiced trauma-informed care, that there's going to be continuity of that care. And we need to understand the law as well. There's a lot we don't know. And I want to now introduce you to the CERSI project. So this is a project, it's an NHMRC grant. It was a targeted cancer screening grant, and it's just been awarded at the beginning of the year. We're just preparing to start it. It's great that the government has actually provided this money to increase, it's called Overcoming Inequity, Increasing Cervical Screening Participation for People with Intellectual Disability. Now, CERSI is someone clever on our team who came up with this. CERSI is an ideal person for us, and especially on International Women's Day. So she's a Greek goddess, initially seen as a witch with lots of potions and lotions, but now sort of absolutely heralded as someone who is actually ahead of her time and empowering other women. Our objective is to update and evaluate a co-design and co-produce suite of resources to support informed decision-making and increase participation in the National Cervical Screening Programme. We're using a disability inclusive approach, and this is the excellent work that the Disability Innovation Institute of UNSW does. We've got the best team I can possibly imagine. So we've also got Professor Jane Usher, who many of you may know from the University of Western Sydney, who's going to be leading on the qualitative work. We've got Professor Eva Stradnova here, so she's the Professor of Special Education and Disability Education at UNSW, who always works with Julie Loblin, who's also a CI on our project, who's a woman living with a lived experience of intellectual disability. We've got Kevin McGee, whom we need a biostatistician, I have to say, because for our SINs, we've decided we're doing a cluster randomised control trial. This is Elaine, who's Head of Health Promotion at Family Planning in Action, teaching, teaching, I suppose we'll say, disability support workers. Ali Carter from the Kirby Institute. We're delighted to have Ali on our team, and Dr. Sally Sweeney, who's a GP researcher from Newcastle. So what are we doing? There's a lot of words on here. I'll just keep it high level, but we're doing in phase 1, in the first year, we're going to be forming our advisory group with the peak bodies, and these will include people with disability, groups with disability. We're actually working across New South Wales, South Australia and Western Australia. It'll include the RACGP as well around the GP piece. We are going to be doing a qualitative exploration of facilitators and barriers and strategies to enhancing screening access, and we're going to be co-designing and co-producing resources and education for people with intellectual disability and their carers and disability support workers and GPs. And we're going to also work out how we can evaluate informed decision-making and health literacy attainment. In the second year, we're going to be implementing our cluster RCT to evaluate the effectiveness and impact of the resource packages compared to standard care. And we're going to be obviously looking at those outcomes in terms of informed decision-making and participation, and do a process evaluation. In the third year, so very exciting, we'll be pulling it all together. I do always sometimes want to think, and obviously our key is to influence practice and policy, and we're going to be working closely as we go with the national roadmap, along the GP pieces in terms of education and upskilling, as well as the attainment of health literacy and supporting parents and carers as well. I do say I want to phase 4, which is where we will have a cup of tea. But I thought I'd just finish just with this look at disability inclusive research. I don't want you all to go to the website. This is a fact sheet which has been written from the perspective of people with disability in the research team. So inclusive research is when people with disability are part of the research team. It looks at issues that are important to them, uses their life experience, and working on research helps build skills and helps people to speak up. Everyone is in the team, helps make decisions, is listened to and respected. People with disability are valued, are paid for their work, must be included from the start. And it's about asking people what they need: extra time, support staff, access travel needs, information they can read, and training. Our minutes now are an easy read. I've been certainly learning a lot. And the interesting thing is around meeting times, of course, must not be too long, have breaks, time to get to know people. I think actually I'd love all meetings, of course, should be like this. So I'd just like to say thank you again, and I'd like to absolutely thank and pay my respects to all my colleagues involved in this project and beyond. Thank you.
Debra, thank you so much for that marvellous talk, and what a rich and compelling series of talks we have had today. I'd like to thank each of our speakers there. We're now moving into the most exciting time of the day, which is the question time. And we do have a question from the floor at the moment, and this question is for Associate Professor Julie Mooney-Phillips. Julie, how do you see SWASH reflected in, or indeed shaping, the contentious field of women's health? Or is its focus on minority gender mean that it's seen as outside this domain? And so the questioner has said that she's interested in broader questions of reorienting women's health to be more inclusive.
Just a small question from Karen then.
Yeah, sorry.
Thanks, Karen. Oh, look, are lesbians women? That's an ancient question, right? I mean, I think that there's there's probably better people to answer this question, and people who will answer it more politically than I will. Does it feel like SWOSH and SWOSH data has been part of women's health in general? No. It was, I remember going to the launch of the Women's Health Strategy at New South Wales Health and being blown over that lesbians were mentioned and that SWOSH was in there, but that it was half a line. And I think that that's, in general, lesbian, bisexual, queer women's health hasn't been seen as women's health. Jean Hale's foundation has only recently, maybe in the last year or two, kind of come on board in terms of talking about sexuality, because they run an annual survey. I think an organization like ACON has been working very hard to get organizations that have responsibilities for women's health to engage with LBQ women's health, and ACON are at the Women's Health Forum that was on yesterday in the Botanical Gardens, and they've been working very hard with a whole range of organizations. So I think there's a question about mainstreaming and about what you kind of have to do in order to be seen within that sector, and what the costs and benefits of that are. Ultimately, I think we have to make the people who are responsible for and have the money to make sure that LBQ women are being served appropriately. The challenge with that, I think, is when it comes to gender diversity, and particularly around non-binary people, and how women's health can or cannot accommodate, but also how gender diverse people might feel comfortable or not feel comfortable being accommodated within those spaces. And I guess that's that's some of the thinking we're doing around SWOSH.
Yeah, it's fascinating work, Julie, and really, really important. So thank you for that, and I hope that we'll have more questions on that. My next question is for Blessing. Blessing, we've talked about community engagement, and I think we've got great agreement from our three experts here today about how critically important that is. How do you go about this in practice? Especially, I mean, you've talked about the diversity of migrant women communities. How does it work for you in terms of engaging the women that you've talked about as being the ones who are potentially overlooked and forgotten in other forms of research?
Okay, to engage with them, first of all, you have to, reach out first. You realize that, first of all, when you're reaching out, the way in which you reach out will actually influence the way in which they accept you in. So when you go there, you reach out with the mentality or with the attitude of, hey, can we have a chat? Can we relate? Because this set of women I'm talking about, they know their left from their right. So so when you go there, don't go with the attitude of, or with the mindset of, hey, I'm coming to help you. So it's more like, what can we do together? Do we have any common grounds that we can strengthen each other? So when you go with that mentality and with that attitude, that's when you can have more engagement. Because at the end of the day, you want these people to relate with you. And it's out of that relationship that you can be able to know what their issues are, and you'll be able to help them or contribute to assistance. So the key point there is try to build a relationship. You don't have to be best of friends, but then there is that relationship. And from that relationship, a whole lot of engagement and a whole lot of things can get opened up for you when relating with them.
Thank you for that, Blessing. And I think that's such an important point to make, that you can't ever try to engage in any community work by taking on a patronising attitude and assuming that somehow the researchers have, all the answer or even all the power, because the reason that you're collaborating with communities is because they are a critical aspect of the research, and the research doesn't work without them, and then their knowledge is a resource that needs to be actually manifested in the research that you're doing.
Yeah,
Bless you.
and one more thing also is most times researchers go into this community with answers already, and they just need to confirm their answers. So they just go there and they're like, we know this is a book, but we need evidence to support the fact that we know this is a book. So at the end of the day, it's more like, okay, give us what we need to tick off this box and so we can move on. And then the people you're meeting, they know what you're trying to do. They know that you just need them to answer a question you already have in mind. And that closes them up because they can see in. So when you go to this community, go there with an open mind. Don't go there, wanting them to confirm what you think you already know, because they can see through that. And sometimes if they want to be politically right, they'll answer the questions the way they know you want them to answer. So you can just leave them alone. Or if you have some incentive, they can just, okay, you know what, bring the incentive, or this is what you want us to say. Okay, you can get it and just leave us alone. So that's, if you really want the truth, you really want your research to actually bring evidence to improve well-being, you have to go there with an open mind and let them answer the questions and relate with you.
I have another question here from the floor. I'll read it out and then I'll assign it. This is from Anya. Really excellent presentations, all highlighting the importance of engaging with community and people with lived experience and building relationships. What are your opinions about how the research landscapes and systems like the ARC and the NH and MRC have or haven't changed in order to accommodate the extra time and resourcing to build meaningful relationships? Julie, I might ask you to address that in the first instance.
We don't get any money from them, so we're fine. I mean, in some ways, that it would be nice to have some funding from the NHMRC to do particularly SWASH, but that's not how SWASH works. But I think in my experience from other projects is that there's an expectation that the work's already happened. So it's unfunded work that happens somewhere else. And so that by the time you kind of get to the point of doing a funded project, it's deep investment. And you can't, I mean, I think what I'm hearing a lot from Blessing is about the idea that this is about long-term relationships. This is not about a kind of hit and run. And I think that those kinds of funding grants aren't supporting that kind of long-term investment and relationship building. And so many researchers are being funded on short-term contracts, and so they go where the work is. And so it's very difficult then to build up deep relationships with communities and to really get a deep understanding of community perspectives and to learn from community. But I mean, I suspect Debra probably has a much better understanding of because she gets the money.
Yeah, Debra, how well funded is the community element of your the research that you were talking about?
Look, it's interesting, isn't it? I absolutely agree with Julie when she says that it's based on those pre-existing, all that work that goes on in the background to be able then to get a grant. I mean, I have to say I'm relatively new to this actually, but as a CIA, but to get a grant and yeah, so there is all that unsung work. You just could not proceed without that. So I absolutely agree. I mean, we've got this 3 years of funding. We know, building those relationships with people with intellectual disability, it's incredibly important that those relationships are sound. All the things that Blessing has said are absolutely crucial to that. It is going to take time. And as Julie said as well, we are going to be, need to put people on short-term contracts and all of those sorts of things, and that is a challenge. So I wish I could say, things have changed. I probably can't tell over time. I mean, I'm delighted that we've actually been given this grant, which acknowledges that people with intellectual disability, this is an area that's worthy of funding in cancer screening. But I'll tell you probably at the end of 3 years actually. But I suspect, I do know that, yes, there are shortfalls, and we need to keep on raising our voices to say actually to do this meaningful research with these populations, and let's say vulnerable populations, people with intellectual disability. It takes time and it takes money.
Thank you for that, Debra. And I was delighted to see that you were paying the people that you were engaging with, because often that is so very inequitable when people are asked to participate in a very intense way in some ways without anything.
Absolutely, absolutely. And it's been really wonderful to be, on its early days yet, but to be working with Eva and Julie from UNSW. You know, they've set out these guidelines, and payment is absolutely crucial for people. And it's often, as you say, it's sort of just overlooked, and you know, and it's important to put that in your funding as well, in your budget.
Yeah. Now, the next question is also for you, Debra. And the question is, do you intend to engage with harder to reach population, such as women with injecting drug use in prison? Oh, sorry, not injecting drug use. This is my misreading acronyms, with intellectual disability in prison. And if so, how are you going to go about this? And also, will you be looking to retrofit existing resources, or are you wanting to design things from the ground up, or are you doing a bit of both?
Right, so thank you. So there's the two questions there. I must say I would love to be able to say that we could recruit in those harder to reach populations, including women with intellectual disability in prisons. But I will say that you know, that's probably because it all takes such a long time, and we do need to do it properly. We are going to use our existing networks, and we are going to be working with big disability organisations with a range of women, some of whom are going to be in out-of-home care, some of whom will be in group homes. But you know, what I'm hoping is, and what we hope with all our research, is that we can build on that, and this lays the foundations for then moving to those groups who are harder to reach. So I think that's a really important question, so thank you. In terms of the second question, well, there's a second bit, I have to remember it now. What was that?
It was about resources, Debra, and about whether the plan
No, very, very important. So in fact, again, I think it will be almost, you know, really within a 3-year time frame, very difficult to start from scratch, but we are building on the existing resources that we have developed from family planning, but we absolutely have to say that these have not been evaluated. So we do, you know, it is a bit of both, because we do need to evaluate actually what works, and it does need to be a genuine co-design and co-production process. So we have got you know, some of our resources to start with. We're not coming in completely cold, but we have to say, you know, when we're talking about putting our ethics through, it is an iterative process. We don't know where we're going to land after that, this first year. So it is a bit of both.
Right, we have another question for Debra, but just before we go to that, I just wanted to ask a question to Blessing. Blessing, we've just come out of this period of time where people have been, you know, literally confined to their homes. And as we know, particularly in Sydney, many people from migrant communities are living in the western suburbs, which was subject to much greater restrictions in terms of lockdown. Has that had an impact on your ability to work with communities, or have you been? And are there any strategies that you've developed around working with people who are essentially, you know, far less mobile and able to actually travel to participate in community meetings and so on?
Yes, with the lockdown, it has really affected people's communication, because, for example, my community, I'm obviously from Africa, we love interacting physically, having meetings and all of that. Yes, it has really affected us at the beginning. You know, it was very hard, but then we got kind of like used to being on, you know, being isolated or being on our own. So we went more into platforms. So you have like the social media, you have a lot of WhatsApp group, and then all that communication kept on going on. And then we had a lot of videoing and all of that. So at the end of the day, we realized that, look, this is what it is. We, you know, this community of people are used to situation changing beyond their control. So it's like life itself has taught them to actually modify or change with the situation. Even coming to a foreign land, we had to change a lot of things. So this was like one of those things that we can't change. We have no control over. So we just go back into that mode of readjust. So at the end of the day, yes, we've been able to readjust and adapt into the situation we found ourselves in, and found other ways like the social media and all of that to be able to interact. And once they had that small break of, you know, you can meet, just use the opportunity to just catch up and get that quick hug that you've missed for a long time and then go back. So yes, the COVID situation affected the community, but normally we brought up that resilience again, and we've been able to really, like, for example, I did a research recently that I had to send out questionnaires, but then I didn't just send out the questionnaires, I had to do a lot of phone calls and then have a lot of talking over the phone and catching up, and then I sent out the questionnaires. At the end of the day, I was still able to achieve what I wanted to achieve, even with the questionnaires. But if there was no COVID, just sending out a questionnaire would have been really hard because people prefer to talk. But since they have been COVID and they're used to that, they had to just modify. But then I had to follow with a little bit of phone calls here and all of that and all of that. So yes, the community have been able to adapt, to modify. It's a mental thing. You know, they are used to changing and doing things that are out of the way they have always known it to be. So this COVID just made them, you know, remember how to readjust themselves to situations or relearn what they've known. They've always known about community coming together, being together. They had to relearn it, you know, just like they had to relearn a lot of things when it comes to Australian culture that is quite different from, you know, where they are coming from. So I think that we've been able to, you know, work well, and I've been able to also work well with my community, coming from that angle.
Thank you for that blessing. It's good to hear of that level of resilience, very heartening. The next question here is for you, Debra. It's from Anne Smart, and she's asking, will a significant part of the grant be allocated to women living in rural and remote areas? And she also, there's a second part, which is to ask, who will be your main partners in the rural areas, if that's the case?
Thank you for that question, Anne. Hello, Anne. So yes, we would love it. I mean, so I have to put some context around that. So we would love to be able to recruit women with intellectual disability and carers, GPs in rural areas. We are working, one of our partners is Scope. It used to be Disability Australia, and they're a state-based organisation. So they've certainly, you know, that capacity is there also in South Australia and then Western Australia. We will need to, we do know that for this group of people, for our, you know, for recruitment, for the qualitative piece of work, Zoom's not going to work. You know, it's all about building that trust. You know, obviously, as we're all aware, you know, research for people with disability has, you know, had a very rocky, you know, unpleasant, you know, not, you know, very challenging time, and we must make sure that we carefully build those relationships, that trust, and that will take, you know, face-to-face time. So again, we will need to look at our budget. I hate to keep saying budgets actually, so, but you know, we would like, you know, absolutely, we want this to be as representative as it can be. So I can't guarantee it, but I do think that we really need to look at that. And I will say to anyone, please do get in touch with me, you know, if you'd like to know more about the research, or if you've got, you know, information, advice, anything that you think will be very helpful for this, because we really would appreciate that. But I think it's a really important point. Thank you. So Scope, in fact, was what, yes, we've got different partners, and you know, this is the largest provider supporter of care for people with intellectual disability in New South Wales.
Thank you, Debra. Julie, continuing on that rural and remote theme, I was fascinated to hear you say that SWASH has this presence in policy that other research doesn't have, and that's fantastic. But I guess it's representative of a population that comes from Australia's biggest city. And how does that work? I mean, how are the communities that you are working with dealing with this idea of, you know, what is happening in rural and regional and remote Australia for women and for non-binary people?
Yeah, that's a good question. I think SWASH has been around for a long time, and I think it's interesting. I mean, I don't know. I'd love to talk to someone who's involved in policy research that looks at the way in which research shifts into the understanding. Most of the citations for SWASH are from reports, not from any peer review work we've done. So it's interesting, it kind of has this parallel life that kind of is in the report space, which I think is much more where policy people are engaging with it. And SWASH is absolutely about Sydney-based LBQ women. That's absolutely what the focus is. For lots of reasons, we've chosen to kind of keep it in that way. I think something like Private Lives, that has a much more national reach, produces lots of very valuable data about both in relation to gender, but also looking across rural and remote communities. And I think, I mean, you know, the kind of claims I made about what the impact that SWASH made was in a world where there wasn't really much more apart from SWASH, and that's not true anymore. There's so much work happening, which is incredibly exciting, and it's happening in lots of different spaces and by lots of different people, which I think is really great. I'm really conscious of, we ran SWASH in Lismore a few years ago, and that was a really important piece of work to do in the Northern Rivers region, because there was a concentration of LBQ women and non-binary people in that area, that it made sense to do that work there, and we could really clearly see that the experiences in relation to health were different to what we were seeing in Sydney. And SWASH is also run in Perth, and it's also run in the Illawarra region. You can see the kind of the geography and the localized nature of the communities and the culture, as well as the different kinds of health issues and how they played out. So that kind of work feels really important. And just quietly, my dream is that SWASH becomes something that any community can take off the shelf and run locally to generate that kind of information, to be able to then go to a PHN or an LHD or whatever to say, we need funding to do something around smoking in our community, or experiences of domestic violence or mental health as a particular issue. I mean, I think that to kind of put those tools back into communities' hands, I would love to be able to do that kind of work, because I think that that localized work, I actually think is really important in the hands of communities.
Thank you for that. Julie, while we're speaking with you at the moment, and I'm thinking of, and I spoke to Blessing a moment ago about the impacts of COVID upon her work. As it's International Women's Day, I feel like it's appropriate for us to also think about the impacts of COVID upon our lives. And I know that you, as a parent of a very young child, will have had an interesting couple of years with straddling not just your research career, but also homeschooling a small child. Can you tell us about how that worked for you? What were your coping
I'm too tired to talk about it, Bridget. I'm so tired. And I mean, you know, I teach, and I've 250 students in semester 2, and so I have seen the kind of the ways in which COVID has just impacted people's lives in all kinds of intense and unexpected ways. All kinds of things about the people normally deal with in their everyday lives, COVID has just intensified. And I think that you know, whilst homeschooling and all that kind of stuff has been sometimes challenging, I've got lots of privileges, and I can see the ways in which that other people's lives in relation to that have been much more difficult, and it keeps me honest. I think that being able to see all those students and the ways that, I mean, so many of our students are frontline health workers, and I don't know how they're coping. I really seriously have such a deep respect for people who have been keeping our health and welfare system going.
Thank you,
but
Julie.
mostly I'm just tired.
Yeah, I hear you. We have another question for you that's just come through, and this it's an anonymous questioner, and they are asking, there's a particular reason that SWASH doesn't use the word gay as one of the identities that women can have, rather you use just LBQ. And this person goes on to say, my experience is the word gay is used by lots of women to describe their identities.
Absolutely. And so it's always hard to talk about SWASH because of the history is so long. And so to kind of talk about what we do today versus what we did 2 years ago versus the 2 years before that. So we used to always ask a question around sexuality, which was, what best describes your sexuality? And there was a question was, I think lesbian, dyke, gay, bisexual, queer, heterosexual, straight. And those were the questions. So I think the way we kind of characterize SWASH in shorthand as LBQ women, there's a whole bunch of people who would be included in that, who we are using that shorthand to cover. I think there's also lots of complicated things around, so language, for example, when we use LGBTQ versus when we use sexuality diverse versus when we use queer as shorthand, that there's lots of people who will be very uncomfortable with language like queer, but equally there will be lots of people who will be uncomfortable with language like gay. So I think that there's always, we're never going to get that right. Although I appreciate people pulling us up and asking us to think about it.
Yeah, those language decisions can be quite polarising. I recognise that, having facilitated a lot of ally sessions, and where we would sometimes speak about gay, and particularly for men who have come from an English background of a certain age, a little bit older than me, who still identify the word queer as being terribly, terribly offensive, and they have lived experience of that being used as a dreadful slur. So yeah, it is interesting the way that we make those choices. Now, we only have 3 minutes left, and I'm hoping in those 3 minutes, if I could ask each of you if you would like to just make a quick, just tell us something quickly that you would like other people to take away on this International Women's Day about either the research that you're doing, or how you think International Women's Day should be taken up by academia, or if it's just a little bit of wisdom or advice for all of us out here participating in this session. Blessing, do you mind if I ask you to go first with that?
Okay, yes. Okay, I would like to bring everyone to understand that when you're doing research, please know how to differentiate between migrant women who come here educated and from refugees, so that you can be able to impact these two sets of women. Migrant women their issue may more tend towards mental health and all of that and sustenance. Meanwhile, the other women, the refugee women, may be more towards accessing of services and maybe domestic violence and all of that, so that these two sets of people can be reached. They can be engaged within the community. And by so doing, you'll be able to have good, empowered women all around. And so that's my take home, my message today. And thank you so much for having me in this.
Thank you so much for your contribution. Debra, what are your thoughts?
Thank you, Bridget. I suppose what I would like to say is support other women. I think, it's a day, we should be doing it every day, of course, but it's good to focus on it. Support other women, whether they're, younger women, whether they're, researchers, but I think it's our, I know as I'm getting, a little bit more elder statesperson, I think a bit older, I feel I really love doing that, is actually sort of supporting other women, bringing people together. I love it then when there's other little sort of offshoots of other groups getting together. And I think it's just that support, and also through our research as well, of course, and obviously practicing what we preach and being inclusive in all that we do. But I think it's all around that sort of support and never feeling, competitive. That would be my message around support.
Thank you for that. Julie?
I was on a panel yesterday for International Women's Day with the Irish Support Agency, which is an organisation in Sydney that looks after the diaspora, the massive diaspora. And there was this awesome woman, a Paralympian, who's probably going to win the Irish Dancing with the Stars this year, called Ellen, who was talking about her experience as a disabled woman. And she said that what people should do is they should just be sound. Now, being sound is an very important Irish phrase. And it resonated a lot because it basically means be grounded, and to me, and it means to connect with the people who are there and to connect with what's happening around you. And I think there's something about just paying attention and being in the moment and being present with the people who are here. And I feel like that's kind of what we're all talking about here, is actually is dealing with what's here. That's it. Be sound.
Thank you, all three of you. It has been a very rich and wonderful afternoon. Wishing you all a very happy International Women's Day, and thank you so much for your contribution to us today.
Thank you, Bridget.
Thank you, Bridget.